I'm going to be talking about the impact of CYP2B6 genotype, TB therapy, and formulation on efavirenz pharmacokinetics in infants and children under 40 months of age. Efavirenz is a non-nucleoside reverse transcriptase inhibitor, which remains an important component of pediatric antiretroviral therapy. The drug is characterized by minimal drug-drug interactions, which is especially important for patients co-infected with TB who may be on multi-drug regimens. Efavirenz has once-daily administration, which leads to ease of dosing and improved compliance. Despite the many advantages associated with efavirenz, there are challenges in dosing infants and young children. Firstly, clearance is affected by CYP2B6 genotype. The three genotypes are GG, GT, and TT. Prior studies have looked at giving one dose to the GT and the GG genotypes and a lower dose to the TT poor metabolizer genotype, but it may be that all three genotypes require a different dose. Different formulations exist for pediatric populations, namely solution, crushed tablets, and open capsules, all of which can affect bioavailability. Anti-tuberculosis therapy may also affect clearance, and it's unclear if age affects the pharmacokinetics. The goal of the current study was to develop a population pharmacokinetic model to quantify the effects of CYP2B6 genotype, formulation, age, and anti-tuberculosis therapy for infants and young children less than 40 months of age. Our analysis drew from three previously published impact studies, namely 382, 1021, and 1070. All three studies included HIV-infected infants and young children. 1070 had a cohort of patients who were co-infected with tuberculosis. There were 19 patients in this cohort. In total, we had 103 participants in the three studies used in the analysis. All three studies utilized sparse and intensive sampling. 1070 looked at dried blood spots in addition to plasma sampling. There were 1,202 plasma concentrations and 561 dried blood spot concentrations included in the analysis. The median dose was 400 milligrams, with a range of 60 to 700 milligrams. 80% of patients had CYP2B6 genotyping information. Three different formulations were used in the studies. 382 and 1021 were almost exclusively solution formulation, whereas 1070 was predominantly open capsules, but a few patients received crushed tablets. We performed population pharmacokinetic modeling using nonlinear mixed effects modeling, non-mem version 7.3. Since this was a pediatric population PK model, we included allometric scaling on clearance and volume of distribution prior to the evaluation of other covariates. We used the standard allometric scaling for a small molecule, namely weight to the 0.75 power on clearance and weight to the 1.0 power on volume of distribution. In looking at the data, the dried blood spots were consistently lower than the plasma samples, so we compared the differences in the model using a scaler. The model evaluated the effects of CYP2B6 genotype, age, gender, and rifampin INH co-administration on clearance. It also looked at formulation on bioavailability. There are many different ways to look at CYP2B6 genotyping in the model. We drew from a prior publication of efavirenz, which looked at a factor of theta raised to the square root of the CYP2B6 activity score, where we defined CYP2B6 activity score as 0 if the patient was TT genotype, 1 for GT, and 2 for GG. We started with a one-compartment model, and this described the data well, so we did not pursue more complicated models. We had a separate error term for intensive and sparse sampling, and used a combination error model, which had proportional and additive components. The table shows the parameter estimates from the final model. Theta 4 was the scalar, which evaluated differences between dried blood spot samples and plasma concentrations. The value of 1.23 demonstrates that the dried blood spot concentrations were 23% lower than plasma concentrations. CYP2B6 genotype on clearance and TB therapy on clearance were significant covariates in the final model, as was liquid formulation on bioavailability. Age and gender were not significant covariates in the final model. Intersubject variability decreased from 86% to 67% from the base model to the final model. In looking at the residual error, The proportional error for intensive samples was 28% as compared to 64% for the sparse samples. CYP2B6 genotype had the greatest effect of all the covariates in the model. You can see in the equation for apparent clearance below the table, it was a factor of 3.26 raised to the square root of the CYP2B6 activity score. What this meant is that the GT genotype had a 3.3-fold higher clearance than TT, GG had a 5.3-fold higher clearance than TT, and GG had a 1.6-fold higher clearance than GT. TB therapy also had a significant effect on clearance. We were expecting the TB therapy to increase clearance due to the effect of rifampin. However, we saw a value of 0.71, so clearance was 29% lower with TB therapy, and this was predominantly due to the effect of INH. The liquid formulation led to a 42% lower bioavailability than open capsules. Our bootstrap internal validation is shown in the table. It converged 96% of the time, and the parameter estimates were well within the 95% confidence interval of the bootstrap. Here are the diagnostic plots from the final model. On the left, the conditional weighted residuals were plotted against time after dose. You can see that for plasma and dried blood spot samples, along with the 3 separate studies, there appeared to be no significant bias with time. In looking at the concentrations as compared to the model individual predicted concentrations, we can see that there is no bias around the line of unity. Therefore, the final model represents the data from the 3 studies well without significant bias. We wanted to look at how genotyping, TB therapy, and weight affected the median trough levels. And we wanted to evaluate this using the 1070 protocol dosing, so performed a simulation of the final model. Table 1 on the left shows the P1070 protocol dosing. This was a weight band-based dosing, and patients with the GG and the GT genotypes received a higher dose than those with the TT genotype. For our simulation, we looked at the 3 different genotypes, TT, GT, and GG. Patients were either assigned to the TB therapy group or no TB therapy group, and were assigned one of 10 weights. We had 200 subjects per genotype, weight, and TB therapy combination, giving us a total of 12,000 subjects. The dosing is shown in the table on the left, the cohort 1 step 1 dosing. Patients are assumed to be at steady state and receiving the open capsule formulation. Here are the results of the simulation. We have trough concentrations. These are the median troughs separated by weight, genotype, and the presence of TB therapy. The goal C trough is shown with the dashed lines. Trough concentrations less than 1 microgram per mil are felt to put patients at high risk of viral rebound, whereas trough concentrations higher than 4 micrograms per mil are felt to increase the risk of CNS toxicity. You can see with the graph on the left, there were dramatic differences between the GG and the GT genotypes. However, almost all of the median trough concentrations remained within the target range. On the left, for patients on TB therapy, those differences between GG and GT remain. However, now the majority of the GT median troughs are above the target range, as are many of the TT trough concentrations. What we've shown here is that CYP2B6 genotype, TT, GT, and GG resulted in significant differences in clearance. The simulation showed that different dosing may be needed based on each individual genotype, especially for patients on TB therapy. And this is because TB therapy led to decreased clearance, likely due to the INH effect. The liquid formulation led to a decreased bioavailability. However, very few patients are receiving liquid formulation, so this may not have as much clinical relevance. Age had no significant effect on clearance. In conclusion, future pediatric dosing recommendations for efavirenz should consider CYP2B6 genotype, formulation, and the presence of TB therapy. I'd like to finish by thanking the participants and their families, the Impact Network, the 3 study teams, and funding from the NIH. Thank you all for your time.